सरस्वती सरस्वती शारदे सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते सूर्य ब्रह्म शिव विष्णु गजानन जिन चरणों को सेवते हम शिशु हैं अज्ञानी माता इन चरणों का प्यार दे वीणा पाणी तार दे तार दे तार दे माँ सरस्वती शारदे माँ सरस्वती शारदे पूर्ण इस अज्ञान उदति से वीणा पाणी तार दे माँ सरस्वती शारदे माँ सरस्वती शारदे
Recording in progress. Recording stopped.
Good evening, everyone. I welcome you all to this Glaucoma Surgical Carnival. And as a part of our annual meeting, we have the Dr. MC Luthra Oration. And we already have Dr. Grover online joining us all the way from Texas, USA. And I'll just like to show a small video about the person on whom life and whose name this oration is dedicated. Audio, please. So he established, the IOL implantation in northern India. He was one of the first surgeons to do it. And initial schooling was at Allahabad and college, and then MBBS, DOMS, and MS from SN Medical College, Agra. And he published various scientific publications and joined ONGC in 1968 as an ophthalmologist, and then established Drishti Eye Center, where my brother and myself we joined later and established the Drishti Eye Institute. And he established various clinical services during the years, like the glaucoma services in '97, Phaco and Retina Unit '98, vitreoretinal surgery in 2000, LASIK in 2001, and also established on the academic side a diploma in ophthalmic techniques in 2000 and microphaco LASIK fellowship programs in 2007. Also established an eye bank, and he had leadership roles in various organizations, as you might have seen in the photographs. And he was the past president of the UP State Ophthalmological Society when the state was undivided, founder president of the UK SOS, past senior vice president of UP State IMA, and chief editor of UP State IMA MS Journal. Various recognition and awards: Mohanlal Memorial Gold Medal Award, Lifetime Achievement Awards for Uttarakhand State Society and North Zone Ophthalmic Society and Equine, and he was honored with various awards at various forums. And on the community side, he did more than 200 eye camps and was very active in the Rotary, and also established the IMA Oxygen Bank and various other camps. So these are some of the past recipients of the Dr. MC Luthra Oration. In 2013, it was Dr. A.K. Grover sir, and 2014, Dr. Mahipal Singh Sache, 2017, Dr. Kumar, Dr. 2018, Professor Mot Gupta, and 2023, Professor Tityal gave these orations. And I'm happy to announce, we all know that he's already joined us online, and none other than Dr. Davinder S. Grover, who is going to deliver the Dr. MC Luthra Oration 2026. I request Dr. Gaurav to please introduce our Dr. MC Luthra orator.
So, welcome everyone for this amazing oration, and we are lucky to have Dr. Grover with us. And it's my privilege to introduce Dr. Devinder Grover. So, Dr. Grover is renowned worldwide. He is dedicated to innovative glaucoma surgeries and complex management techniques, and he's been at the cutting edge of surgical research. He's currently the director of research at the Glaucoma Associates of Texas, and he is part of many significant clinical studies on glaucoma worldwide. So he's been innovating, and he has amazing amount of contributions to glaucoma, and he has developed multiple innovative glaucoma surgical techniques, which have proven to be a big boon for his patients and patients worldwide. He's also a key designer of novel surgical instruments that facilitate advanced, minimally invasive glaucoma procedures. In fact, he's been one of the pioneers of micro-invasive glaucoma surgery. He has almost more than 70 peer-reviewed research articles and publications, which are quoted worldwide. And he's also been an innovative glaucoma surgery educator. He's an invited speaker at most of the international conferences in glaucoma and educates his peers on advanced glaucoma surgery techniques and collaborates with a lot of doctors worldwide. He's also been, very involved with books and global collaborations, and he serves as co-editor of GATT, a Guide to Circumnavigating Schlem's Canal from Around the World, which features 26 expert-authored chapters. And he also focuses the focus on surgical pearls, which is a book which emphasizes on surgical pearls and clinical outcomes, providing valuable insights and guidelines for ophthalmologists. Dr. Grover obtained his MD from the renowned Johns Hopkins Institute and completed his residency at the Wilmer Eye Institute, both of the best places, and furthered his expertise with a fellowship at the Bascom Palmer Eye Institute, which again is one of the topmost institutes, I think number one in the US. He's also into philanthropic initiatives, and in fact, and he's a co-founder of the Cure Glaucoma Foundation. Dr. Grover is committed to enhancing access to care for all patients and promoting research and advancing global education for glaucoma patients. So with that, I think I had to really shrink his introduction, and I apologize for lots of the amazing things that Dr. Grover, which you has done, which I may have missed. But I don't want to hold you back from the oration, which is a lot of people have been waiting to hear from him. So Dr. Grover, with this, I pass on to you, and we are all looking forward to your uh, talk on the Dr. MC Luthra oration on your work. Thank you.
Wow. Well, thank you so much for the very kind and generous introduction, and it's such a pleasure to join you all here this morning, but for you all this evening. Never been to Madhavan, but hopefully one day I will make it over there. But I'm going to speak today on the 5 MIGS talks. I think my screen sharing is paused. I'm not sure we can. Oh, there we go. Okay, perfect. These are my disclosures, many of which are not really pertinent to today. It is just such an honor to honor Dr. Luthra with his dedication to organized medicine, community service, caring for individuals of all backgrounds, and innovating and teaching, which is such an important thing. So organized medicine is so important for all of us to stay together and advance the field. And it's an honor to be a part of this program and honor Dr. Luthra's work. I'm going to speak on 5 MIGS tips. I really kind of appreciate why early intervention is important. Do a past, present, and future of angle surgery just in general, and then wrap up with some intraoperative tricks and some limitations of MIGS. So I caught the tail end of a few key parts of a discussion about early intervention. But let's take a step back. So I've been practicing for about 15 years, and I look back at my training, and when I finished my residency training in 2010 and 2011, all we really had were trabeculectomies, tubes. The OTI wasn't even out yet, and then we had the 250, 350 bar belt, and the surgical approach was trab, tube, and then diode if that didn't work. But in 2011, 2012, I did the first ab internal blood revision. And then the first GAT was performed in 2012. So it's always interesting to kind of take a step back and see kind of where we've been, and why what is this interventional glaucoma that we're now speaking of, and why are we now open to intervening early? That's because a lot of the earlier interventions, or now some interventions, are a lot safer. So when the answer was just to do a trabeculectomy, you really wanted to push until you absolutely had to, because it's such an invasive procedure. But now when there's some microshunts and other minimally invasive approaches, it's much safer to intervene and ideally target patients and get them off drops if possible, or decrease the drops. And why intervene as opposed to drops? There was a great lecture on the impacts of preservatives. But and also a discussion on SLT. But what is this? Why are we doing this, and why is it important? So we all are very familiar with the LIGHT trial and the 6-year outcomes of the LIGHT trial, showing that the latanoprost group was more likely to need cataract surgery, more likely to need trabeculectomy, and they tended to do worse. They had more disease progression. But why was that? We can just say, okay, well, maybe it's compliance, maybe it's adherence, who knows? But is there something else going on? And is it because drops are actually harmful? And when you look at these eyes and what we do to these eyes with medication, it's hard to imagine that what we're doing is good for the eye. And there was a group out of Japan that published a great study in 2022 showing the connection between anti-glaucoma medication use and surgical outcomes. And this was with the Tenedo blade. Hopefully many of you are aware of this. What they did was they looked back at patients that had a Tenedo micro-ab internal trabeculotomy, and they found that basically 4.5 years was the sweet spot. And they showed that after 1 year after the Tenedo goniotomy, if a patient had been on drops for longer than 4.5 years, their risk of failure was almost 50%. That's huge. That's a big deal. 50% failure at a year if they've been on drops for a long time. And nothing's without side effects. And I talk to my patients all the time. They're like, oh, I don't want a laser. I'd rather be on the drops, because they assume that drops are safe, but drops aren't safe. And I think there are a side effect of drops. And when we do this to our patients' eyes, you can't imagine it's inducing inflammation and scar tissue, and probably destruction of the downstream collector channels. So, I think early intervention is something we should start to consider more. And I do think that sometimes early interventions can be safer than drops. And our goal is not only to lower the pressure and prevent progression of a glaucomatous optic neuropathy, but I think it's also to decrease the patient's dependence on drops. So let's take a step back of like the past, present, and future of angle surgery. And I always like to look back at these classic articles. So this is Otto Barkhan, one of his first articles he published in 1936. It's hard to believe it's almost it's 90 years ago. But if you look at I loved reading these articles. It's almost more like poetry than a scientific publication. But he'll say the operation is without danger when the proper technique is used and has proven successful in the writer's hands. And then it says the results are predictable and appear to be permanent. And it says the surgeon can see the area of blockage, which is the cause of glaucoma, and guide his instrument. All the doctors back then were men. Guide his instrument to restore the normal outlet for intraocular fluid. And then this is what he published when he published his outcomes in congenital glaucoma in 47. But he said, what I love this line right here, a plea is made for early diagnosis and prompt adequate operation. So even back in the 40s, they were thinking about early intervention. And this is what Otto Barkhan did. He was an innovator in glaucoma surgery, but this was all before the scope, before using microscopes. So he actually innovated a gonio prism where he would be able to visualize the angle, and then had a medical illustrator to help him capture what he was doing and performing the first goniotomies. And then around this time, as things happen in multiple parts of the world, in the UK as well as in the United States, in Iowa, you had Burrion and Allen in one group out of Iowa, and then Redmond Smith, who was just a tremendous thinker in angle surgery out at Moorfields. And they were talking about ab externo trabeculotomy, and Burrion and then also in Germany, Harms had developed an ab externo trabeculotome, or the Harms trabeculotome, which many of us have used. And then Redmond Smith was using a filament, a suture, a nylon ab externo. And so this was Harms published in the 1960s using his Harms trabeculotome, which I even used when I was a resident. And but this is Redmond Smith's article. What he did was he would cut down and find Schlemm's canal, cannulate it with the suture, retrieve it, cut down, externalize it, recannulate, and then pull. And I love this picture here, number 3, showing how you have that anterior cleavage, and the how it opens up the canal right in the most anterior portion. And he described this back in the 60s. And this is actually an OCT after a GAT. So, showing the same things that he described, basically 60 to 70 years ago. This patient, this is David Rahimi. He was the first GAT patient in the world that Dr. Feldman and I did back in October of 2011. And he presented, he was actually an immigrant from Afghanistan, and he presented with bilateral juvenile open angle glaucoma. And we told him, we said, hey, listen, David, we need to do this surgery. You need an ab externo circumfrontal trabeculotomy. But we think that we can do this without making a big incision. We think we can get into the canal and cannulate it ab interno. And he said, let's do it. And so so I remember, I'll never forget that moment in my life where, I'm sitting there doing the surgery, Dr. Feldman is next to me, and David is on the table. And, I make a paracentesis, I make a small goniotomy, and I'm passing the catheter, and I see the light coming around, and my heart is racing, my hands starting to shake, and it comes around, and I pull it out, and we do a 360-degree ab internal trabeculotomy, and I look at Dr. Feldman, he looks at me, and we give each other like a sterile fist bump. But the moment later, what was exciting was that David, who was there the whole time, obviously, said, "Did you guys get it? Did you guys get it?" And he helped us complete this innovation. And oftentimes when it comes to innovation, it's always the surgeons that are given credit. But we learn from our patients, and we wouldn't be able to innovate without our patients. And unfortunately, David passed away from a very bad cancer just about a year ago. But his legacy and his contribution to the world will forever be hopefully appreciated and recognized, because it was without his courage that we would not have been able to do GAT. So and we've been studying students of angle changes after MIGS for a very long time, after goniotomy, after trabectome, after KDB, after GAT, and we're constantly looking at this picture and saying, well, how can is there a way for us to perform GAT or something similar to GAT, that anterior trabeculotomy, so that we have that shelf fall down, just like Redmond Smith described? Is there a way we can do that maybe a little bit easier? And, we worked closely with Murray Johnstone, who's also recently passed. And Murray really dedicated his life to demonstrating the idea of a motion-dependent outflow, that that Schlemm's canal and trabecular meshwork is not some passive drain, but it's an active pump that moves with diastole and systole. And you can see the Schlemm's canal inlet valves, outlet valves, and the circumferential deep plexus. And we know that with glaucoma, there's a loss of elasticity. The ciliary body moves less, the scleral spur moves less, and the trabecular meshwork moves less. And so Dr. Feldman and I developed a different surgery called IVENT, interventional valve enhancing trabeculotomy. And we designed a unique spatula, and we think it provides that anterior cleavage without destructing all those delicate intracanalicular structures. And it's a simple spatula that's a left and a right. And here's an animation demonstrating, you're sitting temporal, and you want to really avoid going into the canal. You want to stay as anterior as possible, just posterior to Schwabe's line. And you don't want to disrupt any of the beautiful intracanalicular structures, just making the most anterior cleavage in the non-pigmented trabecular meshwork. And you can do, there's a left and a right, and you can treat 3 o'clock hours, 4 o'clock hours, 5 o'clock hours. I kind of titrate it based on the patient's need. And here's a video demonstrating the key portions of the IVENT and the spatula itself. So making a small entry site, you always want to see the sheen of the instrument. And you don't want to go too deep, and you want to stay anterior as possible. And you want to kind of almost pull a little radially, pull towards yourself, so that you really stay superficial. And then you don't want to keep going back and forth, because you don't want to disrupt any of the intracanalicular structures. And then you do the same thing to the right. And when you compare this to other forms of goniotomy, one thing that's most notable immediately is you're not seeing bleeding. And why aren't you seeing bleeding? Well, you're not seeing bleeding because you're not disrupting all the delicate intracanalicular structures. And then again, I'm sitting temporal, so up top is the nasal quadrant. You can see that episcleral venous fluid wave, that blanching of the episcleral vasculature. So here's a case with I stained the trabecular meshwork with trypan blue for a little better visualization. And again, staying superficial, you just see a small little white strip. It almost, and what's crazy is that on gonioscopy afterwards in clinic, it looks almost like nothing was done. And you can look on gonioscopy and look in the nasal quadrant, and you almost see nothing. And you question, well, what happened? Did we actually do any surgery? It's that subtle and minimal of an incision. And what we think is happening is that we're actually improving the motion-dependent outflow. We think that the trabecular meshwork is moving a little bit more posterior, and you're getting some improved movement, improving the elasticity of the trabecular meshwork, and improving the movement of the ciliary muscle and the scleral spur. And again, this is theoretical, obviously, But the potential mechanisms of action that we think are, number one, we're bypassing the trabecular meshwork. Two, we're increasing and moving the scleral spur posteriorly and the ciliary body posteriorly, almost mimicking. You know, Murray Johnstone, when he saw these images I'm about to show you, said, "Wow, it's like you guys are mimicking the effect of pilocarpine." And then we also think that we're providing a dilation of Schlemm's canal, which is improving outflow and improving the pulse valve mechanism. So here's an example of a patient. You know, she has a 15-year history of glaucoma. So I just talked about patients being on drops for longer than 4.5 years. This is a lady that's been on drops for over 15 years, on 3 topical medications and pressures between 14 and 16. She needs cataract surgery. And so you can see preoperatively that you can sometimes never almost see Schlemm's canal, or sometimes a little bit of a slit. You can see right nasally. I'm not sure if you can see my pointer. And then this is what it looks like post-operative month 1, where the Schlemm's canal is actually more dilated. And this is the temporal angle. You don't really see much happen to the temporal angle, but in the nasal angle, 3 months later, you can really see that anterior cleavage and the canal opening up. And this was what blew our mind, is we're actually seeing that you're seeing an arc. You see where the incision site is by the red arrow. We're seeing some type of arc. That trabecular meshwork is curved in. And then you're actually seeing in green that circumferential deep scleral plexus. And actually where that white is it might be an inlet valve. And this is kind of one of the first times, and we're publishing this right now, where the valves have been seen in vivo on OCT. It's remarkable what we're seeing. And in truth, we didn't plan the surgery to do this. What happened is we were doing this surgery just as a minimally invasive way of performing a goniotomy. But then we started seeing patients come in on no medications. And the pressures are 11 on no medications. We're seeing pressures well beyond what we've ever seen with angle surgery. And then we looked on gonio and didn't really see much happening. And then we looked on OCT and we were just blown away by the changes in the angle that we never anticipated. We're seeing this dilation of the canal. I've never seen anything like this after angle surgery. And so what we did was we kind of went back and said, well, what could be happening? And so we kind of tried to, in a backwards way, explain what might be occurring. But this patient actually had a trabectome in the fellow eye back in 2017. You can see the difference of the angles. So I'm going to present some initial data on 140 patients in 218 eyes, the vast majority of whom had open angle glaucoma, primary open angle glaucoma. Their average mean deviation on visual field was about minus 5.76. This was real disease. They had visual field loss. And you can see they had, after 24 months, a sustained and significant decrease in pressure and a sustained and significant decrease in their medication. But let's get more nuanced before. But here, the complications, what's nice is anybody that's done other angle surgeries, even GAT, have noticed the biggest challenge is the hyphema. And that goes away. But what's amazing is because this is such a minimally invasive type procedure, we're not really seeing that significant of a hyphema. Only 6 layered hyphemas at 1 week. And, basically 4% hyphema rate, which the vast majority of the data around the world shows that with other forms of goniotomy, you're seeing about a 30%, 25% hyphema. Now, this is a busy slide, and I want to slowly talk about it. So the first column is the number of eyes. Second column is pre-op IOP. Third column is post-op IOP, mean IOP reduction, the number of months of follow-up, the number of pre-op meds, number of post-op meds. We have different definitions of success. And then the most important thing is the last 2 columns is the number of eyes off all meds, and of those patients on no meds, what's their IOP? So let's look at the second row, which is the more classic definition. We took patients that had high pressures of greater than or equal to 18. Their pre-op pressures, there's 70 eyes, pre-op pressures were 21, and at IOP. But more importantly, they went from 2 meds down to 0.8. And what's mind-boggling is that half the patients, 53% of patients, were off all meds. And so we took patients, half of them, that were on, a pressure of 21 on 2 meds, and at At 17 months, they're on, half of them are on no meds, and their pressure is 14. And across the board, look at this, no matter where we started, half the number of eyes were on no meds, and all of them have settled down to pressures of 12 and 13. It's just things we haven't seen before in angle surgery. So, the post-op OCTs and the low IOP suggest a novel mechanism of action. We think it's due to enhanced motion-dependent outflow. This is a valve enhancing tissue-sparing surgery that's relatively safe with a relatively low learning curve. And, I'm touching on some other ideas that we need to have a conversation about globally, which is the traditional definitions of success and how MIGs don't really apply to that. And here's some examples. If I had a patient that had pressure of 17 on 4 medications and I took them down to 14 on 1, that's a huge clinical success. But by the standard definitions of a 20% reduction on the same or more fewer medications, that's a failure. This patient did not have a 20% reduction. So every FDA trial would consider that a failure, even though every person in the room would consider that a huge clinical success. Look at example 2. I took a patient from pressure 14 on 4 meds to 15 on no meds. That's a failure. Their pressure went up, but I got them off all meds. And in our minds, these are clinical successes, but on basic trials, those are failures. So I think we need to come up with new definitions that more adequately take care of and take into consideration glaucoma medications. And we need much more transparency in presenting data in a way that really gives us more clinically relevant information on how the patients are doing. So let's talk quickly now on the other MIGS tricks. So intraoperative pearls for the beginning angle surgeon. You need to be able to see what you're doing, and you need to understand angle anatomy. And the only way you understand that is by clinical gonioscopy and intraoperative gonioscopy. So even after a cataract surgery, just tilt the patient's head, tilt the scope, and don't do anything, and just look at the angle. And then put your second instrument in there and just get that tactile feedback of what it feels like to be the angle before you do any angle surgery. And then you can start with some lower skilled angle surgeries like the Tonito blade or maybe a Henigat before you try some of the more advanced techniques. This is a nice picture. I like that. You can see a couple of things that are good and bad. One, there's a water stain right here that can obstruct your view. So make sure that the gonio prism is cleaned off. 2, my assistant hands me my gonio prism with Helon GV or viscoelastic on the bottom of it already. And I always have Helon on the viscoelastic on the cornea. You want to avoid any kind of limbal vessels, and you need to be able to see. If you can't see, come out, reform the eye, or wash out and keep the anterior chamber formed. You want to have an en-face view. You don't want to have a head-on view. I can't tell you how many videos I see of people presenting where they're having a head-on view. The dangerous part about a head-on view, if you can look down at this picture below, is that you're coming. If you're on an en-face view and you go too far, you hit the back wall of Schlemm's canal. If you're on a head-on view and you go far, you create a psychodialysis cleft. So it's much more dangerous to not have a head-on view, and it's subtle, and it can easily be modified just with your second instrument or even with a gonio prism. That's a head-on view, and you're going to see that's an en-face view, and it's very subtle, but you want to make sure you see the entire band of the trabecular meshwork. That's a head-on view, and I can push it further to make it an en-face view. So take your time and make sure you have perfect en-face view, and then if you go too far posterior, you're going to hit the back wall of Schlemm's canal, not create a dialysis cleft. And what's the difference between these two views right here? One, I have my anterior chamber formed. People are asking, well, how come your views are always better? It's not because I'm a better surgeon. It's because I'm much more careful about keeping my anterior chamber formed and taking my time and making sure I see what I'm doing and not letting blood reflux happen. If I see that level of blood reflux, I also change my intraoperative positioning. I do every one of my surgeries in the patients in reverse Trendelenburg. I keep their head above their heart. You minimize epispheral venous pressure. You decrease the risk of blood reflux. You decrease the risk of suprachoroidal hemorrhage on the table. Every surgery, be it cataract surgery, tubes, trabs, micro shunts, you name it. If I'm operating on a patient, they're in this position. I'd never operate on a patient that's flat. And then you also want to make sure you're comfortable. Sitting straight up. When I get stressed, my shoulders go up. So, sitting straight up, shoulders down. Make sure you're comfortable before you do anything. This is not a rush. It's not a race. Take your time, be comfortable, and be intentional and meticulous. And then what are the limitations of MIGS? There is some question on whether these are successful in patients with when they don't have an intact outflow system, most times in advanced disease. Maybe IVENT is proving this wrong, but most patients that need very low pressures on no meds probably don't qualify for a MIGS. They need to be taken off blood thinners. They need to be able to limit their activity. They should not have a lot of broad PAS outside of maybe angle closure glaucoma. And they need to be able to, I don't want them to have an unstable lens. You probably won't get them in the low teens. MIGS can fail. And unless you're careful, they can cost a lot of money. And I think we need to talk about cost-effective delivery of care. There's a learning curve. There's so many MIGS coming out. It's hard to have some good comparative data right now. And it's a rapidly changing field. So, in general, when you're trying something new, and if you want to try to innovate, practice in a wet lab. I saw some great pictures on the WhatsApp exchange of the wet labs that you guys are doing. I'm sorry I couldn't be there, but it looks like you're having a blast. Talk to colleagues, have exchanges like this. Every time I try new surgery, I sit down here on this chair in my study, and I draw out every step of the way. And in my mind, I think through the surgery. I watch videos. I always have a colleague in the operating room with me to help me think while I'm in the hot seat. And I have an open door policy in my operating room. So if you ever find yourself in Texas, please come join me. So I think it's important to appreciate angle anatomy and appreciate the idea of pulsed out outflow and postoperative changes in the angle. It's always fun to go back and read about the history of angle surgery because it can help us move forward better. IVENT may be the next surgical steps, and I have a feeling Dr. Devendra, who's also been a pioneer for IVENT in India at Arvind, might be speaking on IVENT later as well. So it's exciting to see his results. And you never stop learning in the operating room. It's a constant learning moment for me. And what I like to think about is to learn to be comfortable with being uncomfortable in the operating room. Never stop learning, never stop changing, and understand that it's okay to be uncomfortable in the operating room. And one of my favorite sayings is back in 650 BC, Archilochus, we don't rise to the level of our expectations, we fall to the level of our training. So before you try anything new, or before you step in the operating room, make sure you're adequately prepared and trained so that you rise to the level that you need to. It's been such an honor to be here. Thank you to the Luthra family and letting me help honor Dr. Luthra's legacy and everything he's done for North India. And I'd like to thank the Glaucoma Winter Surgical Carnival Organizing Committee and the local planning committee. They've been really helpful with coordinating everything. Dr. Shivam, Dr. Gaurav, Dr. Amandeep, and Dr. Saurabh. So thank you so much. And this is my glaucoma family at home, my emotional support group that helps me anytime I need them. So thank you for your time.
Thank you, sir. I hope I could turn the camera and show the faces of our guests. They are all shocked and they are all wowed with such a nice quality videos and the tips you have given. And sir, it's really great to have you here, sir. I remember working with you with Dr. Devendra sir at Arvind Eye Hospital with Dr. Pellman sir was also there, and Dr. Ravi sir used to manage our team. Dr. R.K. sir was there, and we were working on IVENT and the ASOCD findings of it. It was really I also was very shocked, and I'm still, to be very sure, I'm not very convinced that IVENT. I think so. I need to do more ASOCDs and learn from that. And it's been an oration, but still, sir, there were many questions being asked, so I think so. We can take 2-3 questions which they have passed on to me. So for the beginners, like I tell you, sir, this Glaucoma Winter Carnival, we have many novice glaucoma surgeons, novice mixed surgeons. So what do you suggest? What should be the first mixed surgery for a person?
I think I really like the Tenedo blade. That is readily accessible, and it's reusable. It's cost effective. I think the surgical skill involved is very, very straightforward. MIGS would probably be the Toledo blade. But as I talked about, before you even do that, just get comfortable with intraoperative gonioscopy. So if you've never done angle surgery, just do it on a straightforward cataract. After the lens is in the bag and you're almost in the home run, you're already doing your victory dance.
I would request Dr. Devendra sir to please come and accept the award, on his behalf.
Your award will be, couriered and reaching you in a few days, and we are really grateful to you again for joining us. Thank you so much. We still go on. We have a couple of sessions left, and then we have many sessions tomorrow as well. So, and I think everybody's been inspired by your talk. So, I think we'll let you sign off and enjoy your weekend. And someday we'll look forward to seeing you in Dehradun. Thank you so much for
Yes.
joining.
Thank you. Bye-bye.
So we'll continue with the session. I'll request Dr. Arshi ma'am, the moderator of the next session, to kindly, and the chairperson, Dr. Harsha, is there. Shatanshu sir, I